Good afternoon. Good afternoon and welcome. Thank you for joining us today. My name is Meg Beyer. I am part of the Managed Care Technical Assistance Center, MCTAC team, and I'm thrilled to be joined by some of our OMH colleagues on our webinar this afternoon. That's for COVID-19 program and billing updates for adult CDT and partial hospitalization. So I want to thank you all for joining. Just a few questions, actually not questions, but logistics before we dive in. So this webinar is being recorded. The recording along with the slides are going to be posted to the MCTAC website. And for those of you who are logged on, you'll also likely receive a follow-up email with directions on how to access this information. We are also going to be asking you to chat in your questions using the chat box functionality. So you can find that on the right-hand side of your screen and chat in the questions to the host. We have a brief amount of time today for our webinar and some content to get through. So if we're gonna collect all the questions we receive. We'll address as many as time permits. However, if any questions do go unanswered, just know that MCTAC is collecting them all and we'll be sending them to the state so our state partners can also see all the questions that came in and especially address those that were unable to be answered on the webinar today. So with no further ado, I just wanted to thank again my colleague Kevin, who is running the back end of this webinar, making sure everything operates smoothly, for everyone who's joining today, and also for our presenters. So with that, I'd like to welcome Nicole Haggerty, Leah McNabb, Peter Barnett, and Gwen Diamond, who will be our presenters today, and ask Nicole if she would like to take things away and get started.
Thank you, Meg. You can advance the slide. Thank you all on behalf of the New York State Office of Mental Health for the important work you are all doing in this incredibly challenging time. You can advance. Given the nature of the COVID-19 pandemic, mental health providers have had to quickly adjust to dramatic changes in staffing, service delivery, and outreach. Community behavioral health providers offer a critical safety net, maybe now more than ever. As such, OMH has worked with the Department of Health and the Governor's Office to secure waivers that allow providers to deliver services in new and flexible ways, including the expansion of telehealth. The guidance cited in this presentation was issued April 13th. However, the billing and documentation relief you will hear about is effective as of March 7th, 2020, the start of the declared disaster emergency. Okay, can you advance? As OMH relaxes documentation and billing standards, we do also expect that programs will continue to maintain quality services and continuity of care to every extent possible. We hope that the relaxation of billing standards also supports agencies in maintaining current staffing levels. We ask that providers continue to support individuals and ensure access to essential services during the disaster emergency. You can advance. Essential services are services that are especially relevant in the current environment. Delivery of these services do not require updates to treatment plans, service plans, or recovery plans. Essential services are simply intended to support individuals' basic needs during the disaster emergency period. So to start us off, I'm going to hand it over to Leah McNabb to talk about how this affects providers of continuing day treatment programs, or CDT.
Great. Thank you, Nicole. And thank you, Kevin, for helping us out with these slides. So on slide 6, we're looking at essential services that include medication, individual counseling, therapy, and crisis. Support of emotional and physical needs is critical at this time, with the goal being that people feel supported, that they hear from their practitioners at your CDT program, and they know that people are concerned about them and focused on their treatment plan. Next slide, please. So now we'll talk about the program expectations for continuing day treatment. Next slide. So here we outline outreach and engagement expectations for CDTs. Outreach efforts must be documented. Programs should focus on engaging participants that are enrolled in their CDT with the effort of engaging as many participants as possible. The primary purpose of the contact is to engage individuals, assess their needs, and of course to provide needed support. And in addition, it's critical to ensure each person has a list of important telephone numbers, local resources, and a step-by-step plan for contacting appropriate stakeholders when needed. So what natural supports does an individual have available to him or her, and can they depend on those natural supports at this time? And for individuals receiving services from a psychiatrist or psychiatric nurse practitioner, medication management must be provided at least once a month, and this can be done telephonically. Next slide, please. So changes in documentation requirements for the CDT. For existing CDT clients during this disaster emergency period, treatment plan reviews are not required, and they may be postponed as needed. Providers may work under existing treatment plans and provide additional services as needed to ensure people have access to additional support and specific services. And for services that weren't identified previously on someone's treatment plan, they can be added to the plan, and it can be documented in a progress note and approved by a physician at the earliest time available during or after this disaster emergency. Next slide, please. So for new continuing day treatment participants admitted during this disaster period, initial treatment plans and assessments may be established via telehealth capabilities. Specific timeframes for developing the initial treatment plans are waived. Admissions should be prioritized. We hope that each of your programs are open to admitting new individuals as they seek treatment and support at this challenging time. Signatures, including the physician signature and the participant, and all required documentation can be obtained verbally and entered into the case record. And assessments and initial treatment plans should be focused on presenting immediate needs of the individual and with an emphasis on medication management, health, safety needs, and focusing on acute psychiatric symptoms. And treatment, of course, should begin as soon as possible for new admissions. Next slide, please. Utilization review process and procedures internally are on hold if your agency so chooses during this disaster emergency, and it is OMH's expectation that this process will resume once the disaster emergency is over. Next slide, please. So program expectations and billing requirements. So this new guidance allows some flexibility around documentation, of course, and billing for the duration of this disaster and until such time as supplemental guidance is issued. And of course, the new flexibility in service delivery and billing are not intended to establish lesser standards for provision of services and support, once again, with the priority being to engage participants as consistently and frequently as possible to provide needed clinic treatment, medication, and support so that people are healthy and safe during this crisis. And for the next slide, I'll hand it over to Peter and Gwen.
And Peter and Gwen, I think you might be muted at the moment, so if you want to just unmute yourself, or Kevin, if you could unmute our presenters, that'd be great.
Can you hear me now?
Yes, all good.
Oh, great. Thank you. So my name is Peter Barnett. I'm with the Office of Strategic Finance here at OMH, and I'm joined by Gwen Diamond. We'll be walking through the billing changes under this guidance in brief. I just want to emphasize that the release of the billing guidance, which reduces contact standards for the continuing day treatment program, It's really intended to stabilize provider Medicaid revenue during the disaster emergency, where enrollees obviously can't be available to participate in the program as they historically or traditionally have due to social distancing, quarantine, illness, and other factors that are challenging during this period. So it's our hope that these measures will help sustain providers and specifically provider staffing levels and the capacity to continue to serve clients during the disaster emergency period and when we come out the other side. So on slide 13, we've got the minimum billing requirement changes during the declared disaster emergency, which again, we'll emphasize, began on March 7th. Providers may use the full day rate code under the 41 to 64 cumulative hours, which is rate code 4317, for any contact with an individual of at least 5 minutes. If an outreach is unsuccessful or the contact is less than 5 minutes, providers may bill the half-day rate code for the 41 to 64 cumulative hours, which is rate code 4311. And in that case, they should provide clear documentation of the outreach attempt in the client record. And then we'll also note that contacts with collaterals can be billed under the same 5-minute minimum. And in that case, then the collateral rate code, which is 4325, should be used. Next slide, please. So it's important to understand the requirements for the billing modifiers for both telehealth and for claims under the disaster emergency. These modifiers are required to appear on the claim. So here we've got a few examples. If a service is delivered in person and the existing minimum requirements have been met, then there's no need to use a telehealth or this disaster-related modifier. If a service is delivered via telehealth and the existing minimum requirements have been met, then the GT or telehealth modifier should be added to the claim. If a service is delivered via telehealth and the existing minimum requirements are not met, but the minimum requirements under this COVID-19 flexibility billing guidance are met, then the GT telehealth modifier and the disaster CR modifier should be added to the claim. So I think that your program's rate codes will use the GT modifier for telehealth, but there is a reference document on the OMH guidance on COVID-19 webpage that's entitled Telehealth Modifier Use for OMH Licensed Programs. And the link to that guidance is in the guidance documents themselves as well as on this webpage. And that will provide you a compendium at the rate code and procedure code level that indicates which of the telehealth modifiers should be used on the claim. So let me hand it back for slide 15 to Liam and Nicole on partial hospitalization.
Thank you, Peter. Okay, can it go to the next? Okay, so OMH has outlined program expectations for the partial hospitalization program in the same spirit that we heard discussed through CDT. These are baseline interventions and outreach efforts that OMH would like to see offered to all participants of partial hospitalization programs. Programs must make a minimum of 5 telephonic outreach efforts to every individual, at least 1 per day. And programs should continue efforts to engage those participants who are difficult to reach. We understand that not everybody responds to a phone call or a telehealth intervention, but we do want to make sure folks are being outreached to during this time. All outreach efforts must be documented. And the primary purpose of this contact is to engage the individual, assess where they are at this time, provide the appropriate supports and interventions, and ensure that each individual, again, has a list of important phone numbers, local resources, understand what's happening in the current environment regarding safety, or contacting stakeholders as needed. Practitioners may use telephone contact to update assessments, treatment plans, and safety plans. So all of that can be done via telehealth. And for individuals receiving services from a psychiatrist or nurse practitioner, medication management must be provided at least once per month. And again, this can be using the telehealth modality as well. Okay, next slide, please. During the declared disaster emergency, again effective March 7th, assessments and service plans should still be completed to the extent possible. However, signatures will not be required at this time, but agreement obtained from the client and others involved should be documented. So where we realize there might not be an opportunity for paper signatures during the crisis, these things can be documented and reviewed over the phone with clients. Service plans should continue to focus on individuals' recovery and their individual goals. In the current circumstances, services and interventions may be provided outside of the outlined service plan when it relates to the COVID-19 response and need. Okay? Providers may also suspend their internal written utilization review procedures as required by OMH regulation during the disaster emergency, and we ask that that is resumed once the disaster emergency is over. This is not to be confused with the Medicaid managed care or managed care plan utilization management process. This relates to the OMH regulations utilization review process. Okay. And again, as we've said here earlier, same with partial hospitalization, this guidance outlines expectations for programs during the COVID-19 emergency period and then introduces minimum billing requirements for each of these programs. These are to be used during the disaster period or until such time guidance is issued. This new and flexible service delivery is not intended to provide a lesser standard of support, but rather to support providers in this new environment of largely telehealth and where groups and gatherings of 10 or more are not allowed. And so with that, I'll turn it over to Peter, who's going to talk more specifically about the billing standards for partial hospitalization.
During the declared disaster emergency, providers may use the 6-hour rate code, which is 4351 for any contact with an individual of at least 5 minutes. Contacts with collaterals are also reduced to the 5-minute minimum, but the collateral rate code, which is 4353, should be used in that case. And then I think if you flip forward to slide 21, we're going to see the same standards for billing modifiers. Again, I won't go through these in detail, but we expect that these modifiers will appear on claims if they're rendered telephonically, and if they're under the revised billing standards, we expect to see the CR or disaster-related modifier appear on the claim. And if they're both telephonic and under these reduced standards, both of those modifiers should appear on the claim. Our intention, again, is to preserve Medicaid revenue during the COVID-19 disaster emergency period. We are asking for that modifier so that we can identify revenue and claiming that occurs under these reduced standards. And OMH will look at individual providers and see how that billing measures up against their historical revenue standards or against cost. Our intention is to make providers whole and sustain their ability to provide services, retain staff, not to provide a significant windfall during this period. So we will reserve the right to look at and evaluate how individual providers use these disaster-related billing standards and what the impact on their revenue was. I think that's all I would add on modifiers, and I would suggest as we click to the next slide that we have a provider question mailbox here, transformation@omh.ny.gov. To the extent we don't get to specific billing questions in this webinar, we will endeavor to answer any specific questions that you have and have submitted through this mailbox. if we're not able to get to it during the chat session. So with that, I think I'll turn it back to Meg to see if we have any specific questions.
Yeah, thanks, Peter. So just making sure everyone can hear me. I know on the last webinar I forgot to unmute myself. So can folks hear me on this one?
Yes.
Good, okay, good. So I'll go through it. We've gotten a couple questions, so I'm gonna try and make it through as many as we can. So the first question, is it the expectation that services will be provided over the phone now, or are we able to continue to do so are we able to continue to do on-site groups of 5 clients or less while maintaining proper social distancing? This is in relation to CDT.
So,
Go ahead, Nicole.
I was just going to say that I think what you will see in guidance across the state from the Department of Health on our own website is that we are looking for providers to ensure the safety of their staff and clients following all of the advisories that are currently out now, so that we understand much of the current work is being done as a result of that via telehealth. There's not anything that we are going to reference here or that is in effect now that would completely prohibit a provider from establishing a face-to-face contact when it is absolutely required. But I would just caution that providers review the Department of Health as well as OMH website very closely for the proper procedures in respect to client and staff safety.
Thanks, Nicole. Okay, our next question. So if someone usually comes to CDT 3 days per week, are we only expected to outreach on normally scheduled days, or should we be reaching out daily and billing each day for this service?
I would just say that's a good question, and I'm going through in my head kind of exactly what we were trying to establish here. So the spirit of this is that given that individuals are not able to come and access services on site to the same extent possible, especially for these programs that are largely done in group modality, I would say maybe Peter, if you have a thought on this at all, otherwise we can bring it back. I'm trying to capture, how that might work in respect to their average monthly billing. And if you guys have any idea now or thoughts on this, otherwise we'll bring it back to evaluate the best answer.
Yeah, I think that's fine. We should bring it back and think about sort of a two-part question, because the first thought I have really is what are the clinical standards for reaching out to that individual, given that their needs may change during the crisis. But I will say that if there's a client that was typically in program 3 days a week, was not our intention to establish standards such that we would begin billing for them 5 days a week as a vehicle to increase revenue or offset costs. So let us take that question back and think about how to balance those two concerns.
Great, okay. Okay, so this is another question about outreach attempts. So do you need to do 5 outreach attempts per week if you have made contact with the participant already during that week? And actually this is related to partial hospitalization. This is PHP.
So the program expectations that we referenced on the slide, including the minimum of 5 telephonic outreach efforts each week, is really just something that we are trying to establish in terms of a baseline or a bare minimum outreach standard for a typical client or individual enrolled in a partial hospitalization program. So there could certainly be variation on that. We're trying to set the standard of at least 1 per day, given that many of these folks may have been coming into the program on a daily basis. So the intention here is simply to keep that connection and that check-in to assess the individual status.
Okay. The next question someone's asking is, what is the maximum that a provider can bill in order to avoid recoup? They're finding that there's increased contact via CDT as a result of the crisis.
We have not established a specific maximum revenue to or billing increase that would prompt us to do a recovery. We will evaluate it on an ongoing basis and look at individual providers. But I think it is not our intention to be heavy-handed, but at the same time, we're providing these reduced standards to allow for more flexible billing under these circumstances, and we're looking to bring providers back to what their historical, or average revenue and billing levels would be. So if there are substantial additional revenues received, we would reserve the right to look at an individual provider and work with that provider on understanding how they employed these different standards.
Okay. Here we have a question. The next one is around modifiers. So a provider is wondering, do we use both the GT and 95 modifiers? And do we also need to use the U2 and U5 modifier as well?
So that question came up on the earlier webinar. I think we were going to take that back to confirm the use of the U modifiers, but I believe that if the service was delivered through telehealth modality, that we would expect to see that GT modifier on the claim. If the service was administered under these reduced billing standards, we would want to see the CR modifier on the claim. So I think the answer is that we would expect to see all of these modifiers ride on the claim. But the base U modifier, I think, is specific to the plan, and so we're going to take that back and take a look at that one.
Okay, sounds good. The next question, are PHPs still required to obtain authorization from insurances in the current crisis environment?
Yeah, none of the pieces that we outlined today would speak for the individual process and procedures that each payer or Medicaid managed care or managed care organization might offer or require during this time. So these requirements in terms of documentation changes and respective billing requirements speak to that of the state mandated requirements under each of the identified rate codes. And I don't know if Gary, you would want to add anything to that.
Can you hear me?
Yep. Yes, we can hear you.
Okay. I think you answered it very well, that we have not waived prior authorization. So whatever happens with the plan's prior authorization before continues now. If they had prior auth, then they still do unless the plan has chosen to waive it themselves at this point in time.
Okay, thank you. Just scanning the questions that have come in. See here. So for partial hospitalization, will the standard admission of clients still be 42 days?
I am not sure about that. Let me, we'll have to bring that one back.
Okay, bring that one back. Let's see here. Let's see if we can get in one more question. So for CDT billing, this provider is currently billing for full day or half day. While we are in the crisis environment, are we billing the service individually?
So Peter, did you want to
So,
did you want to
yeah,
speak to that?
I guess I'm just thinking, do I understand what the question is? I think you are billing for an individual client for a full day or a half day under this guidance. I feel like maybe there's a nuance in that question that I don't fully appreciate. So that's one maybe we'll follow up directly with the provider on. I think the answer is yes, you would be billing individually for a full day or a half day for a given Medicaid recipient that was enrolled in the program. But that seems obvious, so we'll follow up with that provider if we can.
Okay, great. We'll make sure that provider's name is right next to their question. So with that, we are at this 3 p.m. hour. So I want to just see if the state partners have anything else they'd like to add before we conclude the webinar today.
I think that's it, Meg. Just thanking everybody again for their time and their work during this really difficult time.
All right, thank you, Nicole, and all of our presenters, and thanks everyone for joining. Hope you stay well.